So Dr. Elwyn is here and is a world-renowned expert on shared decision-making. Also risk communication, the design and evaluation of decision support interventions, and the integration of health informatics into clinical practice. He's published over 260 peer-reviewed articles and numerous books. He's co-chaired the International Patient Decision Aid Standards Collaboration since 2000, producing a checklist and instrument that's been published, for example, in the British Medical Journal. He has been a member of the lead faculty and co-director at the Summer Institutes for Informed Patient Choice at Dartmouth College here in New Hampshire. He co-edits the Shared Decision-Making Evidence-Based Patient Choice from the Oxford University Press. And he's developed the option instrument to measure shared decision-making and a patient-reported measure called Collaborate. In 2012, he was appointed professor and senior scientist at Dartmouth College, working at the new Center for Healthcare Delivery Science and at the Dartmouth Institute for Healthcare Policy and Clinical Practice. In 2013, he was given a Lifetime Achievement Award at the 7th International Shared Decision-Making Conference in Lima, Peru. But I think an even greater tribute to Dr. Elwyn and his influence is that one of the physicians here tonight, Dr. Callanan, shared that she had gone on his website and gotten one of the tools, a grid, and has developed her own clinical decision support aids and shared decision-making aids. So for someone like Dr. Elwyn, who has done wonderful things, and to know that clinicians on the ground are using his work every day to improve communication and shared decision-making, I can think of no greater tribute than that. So please join me in welcoming Dr. Elwyn to the James L. Reinertsen Annual Lecture.
Thank you. Thank you very much for that introduction. Very generous. It's really my pleasure and honor to be with you this evening. If you were to have a map of America showing now, Minnesota would be glowing with the work that you've done in shared decision-making. I was in Minnesota a few years ago with Victor Montori and Marcus Tiggerson, who's I think gone to the west side now, had enough of the snow, I guess. But really, there are so many people here. My good friend Larry Morrison, who I knew when he was in Stillwater, one of the kind of real clinicians who's driven this area forward in Minnesota, and many, many others of you who I've met through many meetings. So it's a real pleasure to be in such a community of people who are really doing good work in this area. Let me find my presentation and I can kick off. Okay. So, what was I going to say? Thank you very much, Dr. Sunny Mannion and her team for organizing this. Everything's gone so smoothly, and there's a workshop tomorrow, and again, your organization is impeccable. Thank you very much indeed. Here's a Twitter handle for me, but also more importantly, the Twitter hashtag. Now, I encourage people to tweet in meetings because it means that you're sharing what's happening here with a much wider community immediately. So feel free to do that if you've got a phone or a laptop. I won't mind whatsoever. I think it's a very generous thing to do. Now, you may not know, but I feel very much at home in Minnesota because on long car journeys, I used to listen to Garrison Keillor and Lake Wobegon. And I love this quote. Sex is good, but not as good as fresh sweet corn. Does that mean anything to you in Minnesota? But you know, he also brings tears to my eyes sometimes by saying, it's a shallow life that doesn't give a person a few scars. And this, they say such nice things about people at their funerals. It makes me sad that I'm going to miss mine by a few days. Minnesota, nice, right? This is where I come from. Not the castle. This is an English castle in Wales. How many people know where Wales is? It's on the west side of Britain. It's not England. I live where that cloud is in the mountains, or I used to live, where it rains almost daily. The English had a hard time in Wales. They couldn't really kind of settle us down. And so they built these castles in the 12th century. They're very magnificent castles, but they are actually the symbols of dominance. But I'm from the mountain, and I want to share you a few things from those mountain areas. Here's a place that is very close to where I live. Who would like to pronounce that? It's Llanfair Pwllgwyngyll Gocher Chwyndrobwyll Llantysilio Gogogoch. It means St. Mary's Church in the Hollow of the White Hazel near the Rapid Whirlpool and the Church of St. Tysilio of the Red Cave. So I speak Welsh as a first language, and I learned English when the television came when I was 8 years old. I've climbed these mountains in Wales. This is called Tryfan, also called Killer Mountain, because many people have died on here, foolishly, like me, trying to jump between these two rocks at the top. And I see this as the kind of gap between theory and practice, and I know that you are some of the people that are really jumping this gap between theory and practice in clinical practice. My Sundays when I was growing up, I used to go to places like this. Chapels, not churches. The inside of these places is like this. Now, when I read of the Lutheran religion in Lake Wobegon, this is what I related to. And said, yeah, these people, actually, I think they know a thing about Protestantism and how I lived my life here. The inscription on the wall is Deo Caria Deo, God love is. It's a long time ago when I was attending these places on a Sunday. So, to my title. This is a very conscious title. Deliberating, thinking, considering, turning it over, collaborating, working with, and diagnosing preferences. Diagnosing because I think it's our job to diagnose preference. This is, I think, true shared decision making. I work here and here, and here's my conflicts. Intellectual conflicts, mostly. I've produced the option grid collaborative, and I've produced many of these tools, and I'm going to share one with you later. This measurement called Collaborate, I'm introducing into many studies, and I'll be telling you more about that as well. And I do consult for ME Solutions, which is a producer of decision aids in Chicago. That's a paid position, but I'm not promoting their work tonight. Here's a lovely proverb, I think. Better be slapped with the truth than kissed with a lie. There'll be some of that tonight. First of all, I've got a job for you. In your mind, write, please, in your mind, what's being said in that bubble. And then share it with me. Any suggestions? Shout, because we haven't got time to go to the microphones. Just shout out. Sorry? This won't hurt a bit. Silence listening. Silence, listen. Okay.
What is it that you want from me?
What is it that you want from me? How can I help you today? I have some news to share with you. Keep them coming.
Your labs tell me you need a new medication.
Your labs tell me you need a new medication. Okay. All right. So what I think is happening here, most of you, not all of you I think, but most of you have put the doctor in that role with spectacles, maybe because he looks a little bit like me. But actually, this is the patient. And the patient is saying, I prefer this one. In other words, the patient has been given a bit of information to, what do you think, compare some alternatives and say, actually, now that you've told me this stuff, I prefer this one. I could stop here and now in this lecture. Maybe some of you want me to stop, it's been a long day. But I could stop now because this is shared decision making. Very simple. We do it all the time. We make choices in our lives about what holiday, what school, what car. We compare alternatives and we come up with our preference. There's nothing more complicated to it than that, really. It seems to be hard in medicine. Who's this? Do you know what year it is? 80s, I heard. It's 1982 when he came out with that album. And this is the year when shared decision-making was in that President's Commission document. That's over 30 years ago, right? Over 30 years ago. And if we go back a little bit more to the phrase patient-centeredness, that goes back to the 70s. And a few colleagues in South Africa came up with that phrase, patient-centered care. We've been at this a very long time. And not much seems to be changing if we're honest. So what are we going to do? Well, here's the phrase that seems to have caught people's imagination. It's used very widely in policy documents, in the Affordable Care Act, and so on. It really has risen to the top of the policy agenda. But is it happening in every clinical consulting room up and down the country or the world? I don't think so. And I want to ask you what this is. Any suggestions? It's a pipe, I hear. It's a pipe. Anybody, any vote for pipe? Yeah, quite a few votes for pipe. Well, it's not a pipe. It's a presentation on PowerPoint of a pipe. Well, it's not really that either. It's a JPEG I stole from the internet, which I put in my PowerPoint. And it's not that either. It's a photograph that somebody took of Magritte's painting. And he said, "Ceci n'est pas un pipe." And what he meant was, he made a painting. We wish I had this painting, by the way, but I don't have it. He made a painting of a pipe. And that wasn't a pipe either. It was a representation. And I think one of the problems we've had in shared decision-making is that we've got a pipe problem. We've thought that decision aids is the same as shared decision-making. They're not, and I'm going to try and take you on a journey on that argument tonight. Decision aids are very important, however, because they do this. They provide information about the condition, the options, the outcomes, and the probabilities. None of us, faced with a patient about a particular problem, can keep the probabilities in our head. It's too difficult to remember how many in 100 get this harm, how many in 100 get this benefit. It's just too difficult. Even for the specialists, they don't know it, if they're truthful. These tools help patients evaluate what matters most to them if we've designed them in the right way. They talk to the outcomes that Sanya was talking about, those issues that really matter to people, whether it's quality of life versus length of life, and so on, those issues of preference and goals. They help people make an informed choice. And people have always said they don't replace the clinical encounter. Fair enough. And there's a very important systematic review that many of you will know by Dawn Stacey, and I'm going to go through the results of this systematic review. It's a very important piece of research. And here's the kind of tools that are in that review. This is a photograph of almost the first decision aid made in Boston in the early 80s by Al Mully and Mike Barry and Jack Wemberg. A laser disc by Sony is in that machine. And here's a nurse guiding a patient through it. And as you can see, he's kind of figuring it out, right, with his finger, saying, what's going on here? This was a very complicated decision aid, full of meta-regressions and analyses and numbers and so on. Clearly he's engaged, but it took a coach to help him through the program, a nurse. I'm going to throw this up there because although you can do this with a Swiss Army knife, you're really not very helpful, right, to do this. And this is a tendency to do what happened with decision aids. If you could put the numbers in, if you could put the videos in, if you could put the things in, we'd put them in. And some of them went to 40 minutes and some to 60 minutes. They were very long and they were very integrated. And we gave them to patients in the hope that they would use them. And some did. Here's a photograph from the marketing material of Health Dialogue, and now Healthwise, because they've merged between the foundation in Boston and Healthwise. Here's a video. I want you to think about this video very carefully, just for a few seconds. I'm not going to say anything more at the moment. And here's another video. Patient at home with daffodils watching the decision aid. Okay, I'm not going to say much more about that at the moment. So let's go through the results of the systematic review. We can be very confident that these tools increase knowledge. No doubt about it. Not a massive amount, actually, about 15 to 20% of gain. But that's a lot when you're starting from a low base. And interestingly enough, it's those people who are disadvantaged, who have low literacy, that gain the most. That's very important. People who are starting from a low base gain the most by these tools. And they increase the accuracy of risk perceptions. They help people make decisions congruent with their values or preferences, absolutely. And they seem to reduce the number choosing major elective surgery. You know this. So people become more hesitant, act in their own self-interest, you could argue, when they become more knowledgeable about, didn't realize there was that harm. Let me think about that. We can be less confident that they decrease cost. Not to say that they don't, it's just that the research at the moment is pretty thin. However, and I don't want to be sounding negative here about cost, because I think that when people become knowledgeable and act in their own self-interest, it's less likely that they'll take more drugs and act with risky surgery. It's less likely. Whether that means less cost in the long run, because if you don't take surgery or less drugs, there's always something you have to do. So the cost effectiveness is not always easy to determine. But for sure, more safety, less error, and less risk, for sure, with the use of these tools. And adherence to decision, we can be less confident about that too. There's some good evidence in asthma that people will adhere to medication once they understood and have chosen to use the steroid inhaler or whatever. Legal issues, again, very thin evidence base. But I know that ME Solutions in Chicago sell their tools on the basis that hospitals believe they'll get less litigation if people use these tools. Does it lead to better clinician-patient communication if you give these tools to patients ahead of time, which is the normal way they've been used? I don't think we know. There are very, very few studies that have looked at the communication patterns between doctors and patients when you've given them these tools. Very few. So we have this problem. We've built a technology, but it's got problems. It's got problems as to how do we make it move into practice. Back to this pipe again. What have we got going on here? There's been so much emphasis on decision aids. I believe this picture is fiction. How many of you show a video to a patient in your consulting room and talk to them about it? Hands up. I don't see a hand going up. This doesn't happen, right? Show a video, which is 40 minutes. You do? Sorry? Breast reduction. Okay, great. Okay, so that happens, right? Are you a medically qualified or nursing qualified? Physician, and you do this in the room? As the patient's waiting, great. Okay, so that is a workflow issue, isn't it? You do this ahead of time, absolutely. What I think is a fiction is that people do this in the clinical encounter. But if you can do it ahead of time, absolutely wonderful. My argument is that for the generality, this doesn't happen often. And here's one of the problems we've had with decision aids is that even in Dartmouth, where they've got a center that gives away, I think, around 10,000 of these DVDs every year, we know that when they're sent to patients ahead of time, roughly 30% open them and use them, and we're not quite sure if they complete them. And the question that really is yet unanswered is whether if you send them ahead of time, whether that changes the communication in the room. There's an implementation problem. Now, I know there are some places, and maybe there are in Minnesota, hospitals and clinics that routinely use these tools. Group Health does in Seattle, in Washington State, but they made a massive investment and used 12 surgical decision aids. And they've clearly published on them the Outerburn papers. But in general, if I went to clinics or hospitals in Minneapolis and Paul, would I meet a decision aid? I'm not sure. You help me answer that. I think there's a very long way to go before we're implementing these tools as a standard. And so I want to come to this guy. I don't know if any of you knows about Michel Foucault. Michel Foucault was actually a fellow in Dartmouth in the 80s. He was a sociologist, and he talked a lot about power and the power between social relationships. And then there's this phrase, knowledge is power. If we give knowledge to patients, can we empower them? That's the hope that we've been living on. The difficulty is, I think, that there's some research emerging now that this is a real tough nut to crack. I want to show you some things that, in medicine, this isn't always true. Published on this, a review by Natalie Joseph Williams that showed, in medical practice, increasing the knowledge on the patient side independent of the encounter, doesn't lead to shared decision-making. This is what patients told us in focus groups in Palo Alto. I've read a lot, I know a lot. They're hesitant to share that information with clinicians. I want you to put yourself in this patient position for a second. I've read a lot, and you're hesitant to share it. Why do you think are they hesitant to share it? I have many questions. Can I ask them? Would I be considered a troublemaker if I speak up? These are questions that patients in focus groups in Palo Alto, which is pretty wealthy, pretty educated, told us. And these were people who are wealthy and educated. Would I be considered a difficult patient if I say I disagree? Will I get, and this is a kind of real troublesome issue, will I get worse care if I say I have a different opinion? Patients are really worried when you go under the surface to speak up, to ask questions, and particularly to voice their own opinion. It's difficult to believe, maybe, at times, but this is the reality of the patient world, where they come from levels of lower power than the professional. And this paper is in Health Affairs. So my argument is that just the dissemination of decision aids is not the same as shared decision making. We haven't got this beautiful Escher situation where birds turn into fish, where decision aids turn into shared decision making. And we haven't got the situation where something on paper turns into something really alive in the clinical encounter. So let's go back to this for a second. How do we make this happen in clinical encounter time after time? How do we make it happen? As I said in the beginning, I don't think this is very complicated, but we've got problems. And I think the major problem is not skill, it's attitude. That we've allowed, if you like, the profession to be squeezed into such narrow time slots of, in the UK it used to be 7 minutes, and we've extended that to 10 minutes in general practice or internal medicine. And I think you're doing slightly better in the US on some areas where you've got 15 or 20 minutes. But there's an attitude issue about what's the nature of medical practice, and also whether it's okay to diagnose preferences. Is this my role or not as a clinician? I've talked a lot about skills in my work, and I'm just going to run you now through the skills which I think are absolutely essential if you're going to diagnose preferences. But remember that this doesn't happen unless you've got a positive attitude towards these skills. First, team talk. What I mean by team talk is that you create a partnership with your patient, and you say to them, this is going to be a tough one because we're going to compare alternatives, and I know that's going to be difficult, maybe even new for you, and I'm going to work with you and your family to consider the alternatives. It's going to be a journey. We may not accomplish it today because you're going to give you some new information which you're going to have to think about. And I'm going to take them on a journey. So first of all, form a team. Secondly, give them information about the options. You cannot make a decision without very good information about the options. And I'm going to go into that in a bit. And secondly, do the decision talk. What are your preferences? And this may not happen in that same encounter, because as soon as people realize that they've got things to consider, they need time to reflect and deliberate. Here's the model of that process. Team talk, option talk happens. Then you move people from initial preferences, because they have them, from misconceptions or misunderstanding, through a process of preference construction to informed preferences. I don't think this is that difficult, but it is a process that requires a lot of support for the patients who may be new to this idea. I'm going to take you a little bit deeper into a model which I've called collaborative deliberation. And I'm going to do this pretty quickly, and you can read this model separately. But essentially, it's the same idea. You cannot collaborate and deliberate unless you've got a constructive engagement with that patient and their family. And these are the two verbs, deliberate and collaborate. Secondly, you've got to recognize that alternatives exist. And this applies as to whether you want to stop smoking or lose weight or take a decision around this surgery or that surgery or medication versus surgery. There are always some alternatives. What's the priority for you? Is it to smoke because you're under stress and your life's falling apart? Or is it to lose weight? Or is it actually just to get your life under control, and then at some point we'll tackle those issues? In other words, motivational interviewing and shared decision making are under the same umbrella of collaborating and deliberating. Then comes comparative learning. You've got to learn about the alternatives. What do I do? How do I do it? What are the benefits? What are the harms? What if I do this first and that second, and so on? And then thirdly, build these preferences, construct them. Because we don't have these informed preferences inside us. We have to build them. And then you have to put them together. You have to actually listen to what people are saying about what matters to them and build them into the next steps. So here's that deliberation model again. Tomorrow, we'll go into more depth on this, so those of you that are coming into the workshop, and we'll do role play on this and so on with some tools. When you leave a patient with a decision aid, however good it is, however long it is, however short it is, they become informed, but I'm not always sure they feel supported in taking this into the clinical encounter to have that better conversation. Now, I built decision aids. Actually, I built 3 of them, I think. Here's one of them. It was a website. It took me 2 years and a large grant. Nobody used it. Really. After I used it, it was just sat there on the web. Then I did one for amniocentesis, did a successful trial, published the results. Is it used? No. Nobody goes to it. Same goes for breast cancer. Again, another 2 years. So by this time, about 7 years have gone by, and I've built these tools and made international standards for them. Nobody's using them. I kind of felt, whew, what shall I do? And then we found that in this website, the patients were settling on one particular page. They were all going to this table. Now, you can't see it very well. Don't worry about that at the moment. But it was a comparison table. And from this idea grew the idea of what you've got in front of you, which is called an option grid. Why don't you take a look at that option grid right now? Just take a look at it. I want to just share the layout with you first of all. It's got frequently asked questions down one side, and then options coming down the columns. And I want you to imagine that you're a 70-year-old woman who lives in a very rural area in Minnesota, who's widowed, and who has no real transport. She has to rely on neighbors. And you've been diagnosed with early breast cancer. And you're trying to figure out what best to do. And you've been recommended, actually, to have a lumpectomy with radiotherapy. And then your general practitioner says, okay, let's take a look at the possibilities for you. Let's take a look at what happens when you have a lumpectomy with radiotherapy and mastectomy. And these are what is removed. Cancer lump is removed, or the whole breast is removed. Fair enough. But there's been kind of a recommendation towards lumpectomy, so there you go. And then the question is asked, which surgery is best for long-term survival? And then she reads this. Well, there's no real difference, actually, in long-term survival. So that puts other attributes into play, right? If there's no difference on this one, maybe you should consider some other things. What are the chances of cancer coming back in the breast? She reads this and she takes out a pencil and said, hang on a moment, there's a real difference between these recurrence rates in the breast. In fact, one's double the other, she works out. And she hadn't realized that. And then she reads this. Is there a need for more than one operation? Possibly on the lumpectomy side, because actually the cancer can be there for about 20 and 100. Margin issues and need to go back, or recurrence rates and so on. And then she reads, I'm not showing you the full grid on these slides, but then she reads about how often do I need to go for radiotherapy? She says, well, maybe 6 times. What happens to the breast? Well, actually it gets very tender and sometimes shrivels and becomes painful. And she begins to work out, you know what? The travel, the recurrence rates. Can I have a mastectomy? Maybe that suits my purposes better. And she kind of has a much rounder discussion about comparing the options. This didn't take very long to compare those. And this, I promise you, is based on pretty good evidence. And a lot of breast cancer surgeons have been involved in developing this grid. So I hope you can realize that in a matter of a few minutes, you can compare alternatives using these kind of tools. Are they effective? Well, you happen to have up the road in Rochester somebody who's using these kind of short tools very effectively. Victor Montori and the issues cards, you've maybe heard of those. These are short tools designed for the clinical encounter. And yes, they're effective. And we've got work in a trial coming and also qualitative studies where we're noticing if we give these tools to patients, we put them in front of them, we give them a pen to say which questions are really important to you, the whole conversation changes. People say, well, actually, can you just elaborate on this question for me? Because these tools are very short and they ask questions. And the conversation changes to one that's led by the patient, focusing on those very issues. And we like to put the kind of frequently asked questions as things that are really relevant from the patient perspective. The conversation changes. So we believe that these are effective, and more research on this is coming soon. Well, the question is, will these tools be any more effective, these short tools that create conversations, be any more implementable than the others, the long ones that are outside the room? How do we motivate people to do this? And I'm coming to the last section of this talk now. How do you think we should motivate people to use tools like this when there's everything else to do in clinical encounters? Busy clinicians, pressure from everything else. How do you generate this? Motivation. Is it incentives? Is it carrots? Is it sticks? What is it? My feeling is that we've started from the very wrong place in this field. We've started with the tools. We haven't created the demand for these tools. Not really. There's been policy developments, of course, but not really a clinical grassroots demand. And I'm going to suggest to you that one way of doing this is to hold up a mirror, the rear view mirror. We've got very few of these in medicine, very few usable mirrors. And I'm going to share one with you. I think our major problem in medicine is the lack of a generic, valid, scalable, patient-reported measure of shared decision-making. Patients don't really know what shared decision-making should look like. They've never really experienced it, so ask them to measure it, and they give you high satisfaction results, usually on satisfaction surveys. So the challenge is to get a measure that taps into, were you involved, and were you informed, were your preferences elicited, and so on. And we've had a go, and I'm going to take up the last few minutes sharing this tool with you. Called Collaborate. It's a patient-reported measure, and here's about the development of it. Then psychometric testing, and then some pilot implementation. Development first. One of the problems with these tools in the past is that patients have not been involved in the wording of the items. So we started by talking to patients. 27 adults, in-depth interviews, about half an hour each, showing them some items and wordings that we hope that they would understand. Here are the domains. We wanted to explain, we wanted them to be ensured that somebody had explained the health issues to them, elicited their preferences, and had integrated those patient preferences into decisions. And here's the items. And again, I want you to imagine if you're a patient just coming out of an encounter. And we're going to ask you these three questions, either on a text message or paper or interactive voice call. How much effort was made to help you understand your health issues? The first question. Notice the word effort. Did the clinician make any effort to inform you? How much effort was made to listen to the things that matter most to you about your health issues? And how much effort was made to include what matters most to you in choosing what to do next? This is the final piece. You can listen, you can get an understanding, but if you don't take that into account as you decide the next steps with your patient, you haven't closed the loop. Now, almost all of these words here were tested with patients. They wanted health issues, not problems. They didn't like problems, health issues. Matter most to you was much better understood than preferences. They didn't want the word options or preferences or decisions anywhere near this. They didn't understand them. And to include what matters most, where this item is really generated by a few of the patients said, well, it's great that you're listening, but if you don't take any account of it, it's not worth anything to me. That's what they said. So the items were understood and meaningful, and they were completed in less than 1 minute. And you can imagine, on a 0 to 9 scale, completing those pretty quickly, I hope. We did some psychometric testing, and I'm going to run through this, conscious of my time here. We simulated the psychometric testing. In other words, we sent this to over 1,000 adults, and we asked them to complete these and a battery of other measures as well, other measures in shared decision-making, which are much longer, actually. And we created an animation, just a cartoon, essentially, that showed a patient and a doctor working together. And we had 6 different versions of these. One, there was no shared decision-making at all, and the other one was the best we could script. And they were scripted. So from no shared decision-making right to the very best. And we gave these on random order to these over 1,000 people on the internet. And here's what we saw. When you had high shared decision-making, people scored highly on the collaborate score, and vice versa. When you had low or no shared decision-making, the scores were much lower. So this scale discriminated between high and low shared decision-making on these 3 items. We did concurrent validity, interrelated ability, and responsiveness to change as well, and these were all positive. I'm not going to bore you with the details of those, but I could send you to the paper. In other words, it had pretty good psychometric properties and was discriminating. I think clinicians and teams would be very interested to know what their scores might be, so that you can compare, are we doing this? Are we not doing this? If we're up in the 90s, all well and good. If we're at the 4%, maybe we should take a look. Maybe we should take a look. And then you have to go to more diagnostic measures and audio tapes and interview clinicians and interview patients and say, what's going on here? But as a screening tool, we think that this has the potential, and I'm not saying any more than that at the moment, has the potential to hold up a mirror for practice. And I think this will be the motivating factor, not the availability of decision aids. Because I promise you that when we introduce these scores into clinics, people say, give me a tool to help me get better scores. And if it's short, all the better. And if I can print it from a web on a PDF, all the better. And if the patients can have it for 10 minutes before they come and see me, all the better. Because I don't want to waste that time the patients reading it. If they can't read it, sure, I'll go through it with them. But give me the tool that gives my collaborate scores up will be, I think, the way to tackle this challenge. So let me summarize, and I'm sorry for talking so long on this. Let me summarize. Patient decision aids are great, but they're not enough, right? They're just not enough. I think we need to create the demand for these tools and different sorts of tools. I'm pretty convinced that something short that you use in the encounter is more helpful than creating one that you use for 30 minutes outside, but that's my bias at the moment. I think you're going to measure collaborative deliberation. Collaborate is not the only measure. That happens to be short, but you've got to measure this and provide that feedback back to clinicians quickly, in real time, if you can. Not in 5 months, not in 3 months, next week. Make it real for them. And I think you've got to provide easy, frugal, fast tools. What we've also discovered is that when I give clinicians these tools to use, they don't get it. Not immediately. It takes about 3 goes, maybe 4, before they say, now I know how to use this tool in my encounter. Because you've got to share it. You've got to introduce it first, explain the layout. Then you've got to share it, put it on the table, go walk them through. If possible, give them a pen to say, it's yours, you mark it up. And that transfer of power by giving them a pen is the magic ingredient in my view. And then you've got to go silent. Just wait for people to understand it. Preferably, if they've read it before, all the better. Show them how to use it. Doesn't come naturally. And reward positive behavior. And I don't mean financially here. People who do this well are the leaders of the future. Reward them professionally and reputationally. And say, okay, you show others how to do this. I think this is a pretty simple behavior, but it's taken us 3 decades, I think, to kind of get to the, how can we do this? So that we have patients after patient after patient walking out the door saying, I prefer this one. Be well, do good work, keep in touch.